Second session of PhD dissertation research at the 7th Annual Academic Symposium at the Betty Irene Moore School of Nursing. I'm Janice Bell, the Associate Dean for Research, and I'm also the Director of the PhD program, and I'm going to be moderating this session. Before we get started with our presentations, I'd like to introduce our Dean, Stephen Kavanagh, who will say a few words of welcome.
Good morning, everybody. I'm so delighted to be able to be present at your event today. I know how much work it's taken to get you to this point and all the support you've had in doing that. And I think sometimes it's important for us to recognize that, not just your faculty and clinical colleagues, perhaps, but also family and friends. And I know it's always a team effort, and congratulations, clearly. For a college and school like ourselves, this is in many ways the pinnacle of our academic year. It celebrates and recognizes the fantastic work that's been done by yourselves as our doctoral students. It also is very important in terms of cementing a School of Nursing in a university like UC Davis, where so much emphasis is placed on research, quite rightly so, and that our contribution to that is real and directed towards patient care, which is very much a goal of the system. And I know, having read through some of the introductions of the presentations we're going to hear today, how much that's focused on both your own interests in research, but also how important it is for clinical care. You know, we need the best and brightest minds we can in healthcare right now. We need to think about evidence. We need to think about ways of improving what we do. And I'm so delighted to be part of an organization that values what we do. And I'm looking so much to listening to what you have to say, given that, of course, we come from a long heritage of scientific nurses. As many of you know, this is the 200th anniversary of Nightingale, who might be considered a founder of science and inquiry and numeracy in nursing. And it is very interesting that we might track our history to that point. But today we look forward. We look forward to the fantastic success and achievements you've done. And personally, I'm delighted to be able to be here and wish you every success. I'm looking forward to hearing your results and your ideas. Thank you very much, Janice.
Thanks, Dean Kavanagh. So thanks to everybody for tuning in. We're going to have 4 speakers this morning. You can see the agenda here. Each of the speakers has about 10 minutes to present their work. And after each presentation, we'll have about 5 minutes left for questions and answers. And if you'd like to participate in that question and answer session, you simply type your question into the chat, the question and answer function that you see at the bottom of your screen, or maybe it's at the top. And I will read the questions to the speakers and they'll answer then. So let's get started. And I'd like to introduce our first speaker, who is Bola Olariwaju Adewumi, and her dissertation is entitled "The Role of Armed Conflict in Malaria Chemoprevention Among Pregnant Women in Sub-Saharan Africa, 2005 to 2015, and her dissertation chair is Jill Joseph.
Great. Thank you, Dr. Bell. Good morning. Thank you for this opportunity to present a portion of my research that I've been working on for the last few years. So, what is malaria? Malaria is a life-threatening disease caused by the bite of an infected mosquito. In 2019, 228 million cases, and there were 405,000 deaths worldwide. However, the burden of the disease is in sub-Saharan Africa, and they represent about 93% of all cases and deaths. And this is seen among the vulnerable population of pregnant women, their fetus, and children under 5. So the World Health Organization supports multiple control strategies to help prevent malaria. A strategy specific to pregnant women is the use of chemoprevention with medication called sulfadoxine pyrimethamine. This is recommended for women who live in moderate to high malaria transmission areas in sub-Saharan Africa. It is recommended that dosing start early in the second trimester for all pregnant women who are at risk. However, despite the drug being known to be safe and efficacious, there still remains low chemoprevention uptake among pregnant women. The WHO has set a goal of 80% coverage, and sub-Saharan Africa has been well below that average at about 30%. Also, on the African continent, they have experienced varying degrees, lengths, and intensity of armed conflict. It is well documented in the literature that armed conflict can lead to reemergence of disease and epidemics. During conflict situations, there is also a disruption in healthcare infrastructure. We find that health systems are unable to provide services, that supply chains are disrupted, and medications and supplies are not able to get to targeted areas, and there's restricted individual access to care. So why is this so significant? Well, we do know that armed conflict can weaken malaria control programs, as well as disrupt the health services and restrict the antenatal care for pregnant women. And in sub-Saharan Africa, more than 50% of pregnant women live in these high transmission areas and are in need of chemoprevention. But the rates still are suboptimal. No study has looked at the role of armed conflict on malaria chemoprevention in sub-Saharan Africa for pregnant women. So my aim was to estimate the strength of the relationship between a comprehensive indicator of armed conflict and World Health Organization defined malaria chemoprevention uptake among pregnant women in sub-Saharan Africa. So this was done doing secondary data analysis of the demographic health surveys between 2005 and 2015. This study period was selected because during this time, most countries had adopted a similar malaria chemoprevention policy. After reviewing the data, 20 countries met eligibility, and there were 42 data sets. I retrieved conflict information from the Armed Conflict Location Event dataset. This database is collected in real time with armed conflicts of varying degrees through the USAID. At the individual level, I restricted it to moms who had given birth within the last year to avoid recall bias, as well as to those who received antenatal care, because this was the most likely route of receiving chemoprevention. So for my analysis, I used multi-level logistic regression to account for the nesting within the data. So at level 1, we had the individual or the pregnant mother. Level 2 was the year the survey was collected, and level 3 was the country in which the survey was collected. Statistical significance was set at 0.05, and the outcome variable was the receipt of malaria chemoprevention. So I was looking at the odds of the mother actually receiving chemoprevention. So beginning with the univariate analysis for the results, we found that within this sample, the average age was 27 years old. The majority did live rurally. Most had little or no education. And less than half had low income and the other had high income. We also looked at the number of children that they had. So more than half had given birth to at least 3 children, and most had started antenatal care in the 2nd trimester. The mean number of antenatal clinic visits was 4.35 for this sample. So when looking at the odds of receiving chemoprevention, we found that those living in urban environments had 1.2 times greater odds of receiving chemoprevention compared to those who lived rurally. Similarly, those who had at least secondary education, which is the equivalent of at least having a high school education, also had 1.2 odds of receiving chemoprevention compared to those with little or no education. And then those in the highest income group, so I set the reference group as low income. So high income had 1.2 higher odds of receiving chemoprevention compared to the low income group. And then for women who had at least 3 children, the reference group was set at having 1 child. So women who had at least 3 had 1.2 higher odds of receiving chemoprevention. Those who sought care and initiated care in the 1st or 2nd trimester had 1.4 higher odds of receiving chemoprevention compared to those in the 3rd trimester. And at the country level, the higher GDP for the country, the more likely they were to receive malaria chemoprevention. And this actually was 11 times the odds. So what about armed conflict? Well, surprisingly, we found that armed conflict did not have a significant relationship to malaria chemoprevention at the year level or the country level. But what we did find was that individual level predictors did have a significant relationship to the outcome. And this was actually supported in the literature, and our results were very similar. And then finally, the annual GDP of the country had the largest effect on whether or not pregnant women would receive chemoprevention. Thank you so much for your time. And I just also wanted to take this opportunity to thank the members of my dissertation committee, Dr. Jill Joseph, Dr. Shelley Blossage, and Dr. Michelle Sang, as well as the qualifying exam committee, Dr. Gerald Kango, and Jessica John Murray.
Thank you, Bola. That is a wonderful study. And this represents an incredible amount of work in terms of managing all that data from 42 different data sets. I wonder if you could talk to us a little bit about how you measured armed conflict and what definition you used, and whether you think that might play a role in why that variable wasn't significant.
So we were looking at violence. So within this ALCD database, they have various measures of violence. So it could be anything from a civil war to a violent protest, remote bombings, airstrikes. So we use that as our measure. And then we also were trying to, how do we balance this across various countries? So we decided to use a monthly average conflict. So we divided the number of months that we had for data collection and the period for when women would have been pregnant, and then also looked at the number of conflicts that they had. Using that ratio, we were able to then kind of even the playing field for all the countries so that they were based on the same ratio.
So was there any way to try to think about like more conflict versus less conflict and thinking about that in a sort of scaled fashion?
Yes, so within this data set, there were varying degrees. So some countries had no conflict at all. Some had low conflict, some had high. But I think what I discovered later on is that because of how the database is set up, I can't link where the mother lives and where the conflict is happening. So I think if you're able to link those two together and actually be able to see for women who are living in this particular region that's experiencing this level of conflict compared to a different region, I think the results would have been different.
Okay, thank you. We have another question here about the medication, and was that distributed at the antenatal clinic visit, or did that require a secondary visit to public health or other distributors? And I think just sort of on top of that question, I noticed that the antenatal visits were quite low in this population, and could that be another reason that people got or didn't get their prevention?
So the first part of the question, how were they receiving it? So yes, typically you would receive it at the clinic. When I was doing my literature review and looking at barriers to getting chemo prevention, there were barriers on the institutional level. Did they have the medication or not that day? The provider level, did they remember to offer it? Did they think that they didn't need it? Was there some bias there? And then the individual level too, as well. Were they having to share a drinking glass in order to take the medication? Because they do direct observation therapy, so you take it in the clinic while you're there. And then there's some places where there was a fee versus other places where it is supported at the country level and it's free to get the medication. So those are also varying factors. And then what was the second part of your question?
Just that the rate of prenatal visits looked quite low, so everybody was getting an average of about 4. Could you just speak about that? Is that common or?
Yes, so I did find that that is a common finding, to have around 4 prenatal visits. And then the more children that a mother had, her prenatal visits actually were a little bit less. Some of that was due to her own personal knowledge, previous pregnancies and deliveries, financial restraints, social restraints in order to get to clinic. So 4 is about average.
Thanks so much, Bola. I don't see other questions at this point, so we'll move to our next speaker. And really, congratulations on wonderful work. So the next speaker is Brenda Chagoya, and her dissertation is Socio-demographic factors, health-related characteristics, and health behaviors among women with emergency department use during pregnancy. And her dissertation chair is Jill Joseph.
Thank you. Thank you, everyone. Again, my name is Brenda Chagoya, and I am a PhD candidate at the Betty Irene Moore School of Nursing. My area of study is emergency department use during pregnancy, specifically understanding individual socio-demographic factors, health-related characteristics, and health behaviors of pregnant women. So I will be continuing the pregnancy theme that Bola started. Pregnancy is typically a time of increased healthcare utilization due to the frequency of prenatal care visits. As many as 1 in 2 women use the emergency department during pregnancy. A report from California examined all pregnancy-related deaths that occurred in the state from 2002 through 2007. The report found that 2/3 of women had emergency department use during the prenatal or postpartum period, and that nearly 40% of these women had more than 2 emergency department encounters prior to their death. More studies are needed to better understand this critical topic, including rates of use and individual factors associated with emergency department use during pregnancy. Current literature indicates that 20 to 49% of pregnant women have at least 1 emergency department encounter during their pregnancy, and this is in the United States. Prior studies on individual characteristics of women with emergency department use were separated into 3 categories, including socio-demographic factors, health-related characteristics, and health behaviors. Socio-demographic factors such as maternal age less than 25 years old, women who were single, had public insurance, or lived in the South Atlantic region of the United States were found to be more likely to use the emergency department during pregnancy. Health-related characteristics including asthma, obesity, hypertension, pre-pregnancy diabetes, and gestational diabetes were associated with emergency department use during pregnancy. Additionally, women with health behaviors such as smoking, prenatal drug use, less than adequate prenatal care, or delayed entry into prenatal care were also found to be more likely to use the emergency department during their pregnancy. The purpose for my study was twofold. First, to describe the rate of emergency department use among pregnant women, and two, to examine socio-demographic factors, health-related characteristics, and health behaviors associated with any emergency department use among pregnant women. My variables of interest were my dependent variable was any emergency department use during pregnancy, and this was dichotomized as yes or no. So if they had at least one prenatal care, emergency department visit during pregnancy, they were included in the yes group. There were 12 independent variables that were included, including maternal age, race, ethnicity, insurance status, marital status, gravidity and parity, pre-pregnancy BMI, diabetes, hypertension, smoking status, illicit drug use, and prenatal care adequacy. And these independent variables were chosen based on prior literature. The methodology for my study is a retrospective cohort study conducted in a single large academic health center located in Northern California. The hospital had approximately 88,000 emergency department encounters and 1,700 births annually during the time period of the study. Women at least 18 years old who had a live birth between January 2015 and December 2018 were included in the study. Women who lived more than 60 miles from the hospital or who were incarcerated during their pregnancy were excluded. The study used data collected from the electronic health record and from a state database that combined maternal and newborn data. All variables were evaluated using descriptive statistics, bivariate analysis, and logistic regression. The results, so I had 3,882 women in the study. The rate of ED use among these women was 14.3%. They had at least one emergency department encounter during their pregnancy. The adjusted model, so these are the results of the adjusted model. I've crossed out the ones that were not significant, but the variables that were significant were younger maternal age, minority women, so this included Black, non-Hispanic, Asian, Pacific Islander, and Hispanic. Unmarried women, women who had public insurance, had higher gravidity, so that's the number of pregnancies greater than 20 weeks, were current smokers, or tested positive for illicit drugs during the birth admission, were more likely to have used the emergency department at least once during pregnancy. 3 areas provided unexpected results. First, the emergency department use. Second, race and ethnicity. And then third, prenatal care adequacy. First, emergency department use was found to be in the study 14.3%. This is lower than the rate of emergency department use in prior studies, which was about 20 to 49% reported. There may be a couple reasons for this lower rate for our study, because first, our study was conducted in a hospital that's in an urban area where several emergency departments are in close proximity. Emergency department use among women in our study may have been underreported since they did not capture emergency department use that occurred at other local hospitals. Secondly, women presenting directly to labor and delivery department for emergency care were not included in the emergency department use. This distinction is important because each hospital creates its own workflows and processes for how pregnant women present for emergent unscheduled care. These decisions contribute to the variation in rates of reported emergency department use during pregnancy in the literature. Our study found a strong association between race, ethnicity, and emergency department use. Although we expected to see some association, it was a stronger association than we expected, even with all adjusting for all other independent variables. Women who were non-Hispanic, Black, Asian, Pacific Islander, and Hispanic were more likely to use the emergency department during pregnancy compared to white women. This study supports evidence of broader racial and ethnic disparities among pregnant women, which have been documented in other studies. For example, studies have found that minority women were more likely to have preterm births, low birth weight infants, fetal deaths, and have higher maternal mortality rates than women who were non-Hispanic white. Factors contributing to pregnancy disparities are not fully identified. Implicit bias training has been recommended for obstetric clinicians as one way to reduce disparities in maternal care. In 2019, the California Dignity in Pregnancy and Childbirth Act required implicit bias training for obstetric clinicians in hopes of improving pregnancy outcomes. Finding from this study supports the need for interventions that can better address maternal care disparities, such as implicit bias training for emergency department clinicians treating pregnant women. Surprisingly, we found that adequacy of prenatal care was not associated with emergency department use during pregnancy. This was not the same finding as a prior study. While adequate prenatal care helps prevent pregnancy complications, many tools that evaluate prenatal care adequacy do not measure the quality of prenatal care or the individual's access to unscheduled prenatal care. Although this study used a validated and widely used measure of prenatal care adequacy, there are limitations because it does not assess the subjective experiences of women. Given the unexpected non-effective prenatal care on emergency department use during pregnancy, a post hoc analysis was conducted to test the effect of prenatal care and race, ethnicity on emergency department use during pregnancy. However, the interaction effect of race, ethnicity, and prenatal care adequacy was not significant. In other words, there was a lack of relationship between prenatal care adequacy and emergency department use. Prenatal care adequacy and the emergency department use was similar across all race and ethnic groups. Lastly, I would like to thank my family, friends, cohort, committee members, and the Gordon and Betty Moore Foundation for all of their support during this process. Questions?
Thank you, Brenda. Congratulations on wonderful work. Can you talk a little bit about emergency department use during pregnancy in terms of its preventability versus sort of representing access barriers, or what do you think that yes/no emergency department visit represents?
Yes, thank you. So that would lead to future research, because I think there's a difference between people who are in a car accident and have to go to the emergency department as opposed to somebody who's going for something that could potentially be cared for in the prenatal clinic or the primary care provider. That is something to look at in the future. Some studies have looked at if the person is discharged home, that is considered non-emergent emergency department use. This is in the general emergency department literature. They have not looked at that for pregnant women. But there is that dichotomy of emergency department use that's really emergent needed and emergency department use that potentially could be, that condition could be cared for in the outpatient setting.
Thank you.
Thank you.
Were you surprised that chronic medical conditions were not associated with ED use? And why did you exclude women? I guess that's a second question. So let's start with that one.
So initially I was expecting, pre-pregnancy diabetes, pre-pregnancy hypertension, obesity would be associated with emergency department use. And it was found once we adjusted for all of the variables that it was not. When I looked back and went and reviewed the prior literature, none of those studies that found associations with chronic medical conditions adjusted for race and ethnicity, or very few other variables at all. So I think it just didn't come out because of the lack of variables that were being used in their studies.
Could you talk a little bit about why you excluded women who lived more than 60 miles from the hospital and women who were incarcerated?
Yeah, so women who live, since this is an academic medical center, there's a lot of women that get referred to the health center for high-risk care. And because they live so far away, they do come for prenatal care visits and delivery. But if they actually are needing emergency care, they may not drive that distance to be seen at the emergency department at the hospital they're delivering at. So they may be seen at an emergency department closer to their home. And then incarcerated women don't have the same freedom, obviously, to go make decisions for themselves around seeking care. So they may be higher or lower, I don't know, but I thought that it would be not the same as, women out in the community setting, and that's what I was interested in studying.
That makes sense. Can you talk a little bit about this sort of ED use in pregnancy in the context of COVID-19? What are you seeing now, and how do you think the results might be different?
Yeah, so what I've noticed just anecdotally as a labor and delivery nurse in the hospital is less people presenting, at least up in our OB triage area. And also, I believe that that's occurring in the emergency department as well. Women are staying home, and I mean, pregnancy is a very vulnerable time, and I think women are definitely staying home and not coming to the hospital. The concern has been, are they also staying home for their prenatal care visits? So there's been some education put out to people to let them know that prenatal care, going to the clinic, is safe and encouraged to continue their prenatal care.
Thanks. Just one last question, and that is the role of insurance or uninsurance. And did you account for that, and what did you find in that way?
So I did account for insurance. In California, all pregnant women are eligible for some type of insurance. And women with public insurance were found to be more likely to use the emergency department during pregnancy. I know one study I looked at just did public versus private insurance, but then they also looked at women with and without insurance. That was not, in California, that's not really, we don't have that. So in California, all women have insurance, or all women have the opportunity to have insurance. Whether they actually have access to care, comes up to my question is, just because they have that insurance or they get the prenatal care visits, which is where I was interesting to look at the prenatal care adequacy, because prenatal care adequacy is only based on the number of visits. It's not based on quality or access to care. So these women may, even though in California they have access to insurance, they may not have access to care. That doesn't necessarily equate and mean the same thing.
Thank you so much. We'll move on to our next speaker now. That is Carla Hodges, and her dissertation is New Fit for Life, a study of health, physical activity, and perceived discrimination among African-American women. And her dissertation chair is Elizabeth Rice.
Hello, everyone. My name is Carla Hodges, and I am here to present my work that's in progress from a study of Bay Area African Americans. I seem to be having some technical difficulties. First, I want to take a step back and give you a little background on why professionals like me devote ourselves to public health. We work with factors that influence health called social determinants of health, and these include economic and physical conditions in the environment in which people are born, live, work, play, and worship that affect health, functioning, quality of life, outcomes, and risks. In the real world, more care is provided outside of the hospital and in the community, with people caring for themselves and their families on a day-to-day basis. Broadly, we look at ways to improve health before a hospital is needed. The social determinants of health all play into the access that people have to health and health-related activities, places to play and take walks, and an ability to get to and from work and school, gun violence, exposure to gang or drug activity, other violence, including racialized violence, unfair or unequal policing and incarceration, as well as inconsistent or non-existent access to high-quality health care. Due to a variety of social, political, and historical factors, minorities are even more affected by the social determinants of health. Health disparities can be defined as poorer health among members of disadvantaged racial or ethnic groups as compared to members of our society that have the best health. Health disparities have tremendous monetary and social costs. $229.4 billion in direct medical expenditures and $1 trillion in indirect costs are associated with illness and premature death, and indeterminable both psychological and emotional costs to the individual and family. These disparities in care persist despite efforts to improve care for underserved patients, racial and ethnic minorities, the uninsured, poor or low income, those on Medicaid, and non-English speakers. And this crisis places 1/3 of our nation's citizens at risk. And this is not just related to access. Evidence suggests that racial and ethnic minorities receive lower quality and quantity of healthcare compared to whites, even at equivalent access. And there's also higher incidence of mortality, as well as lower rates of proven interventions for a number of diseases. And some of the factors include lower screening rates, worse follow-up, different health beliefs, lower adherence, as well as worse patient-provider communication. And these disparities exist across the age spectrum, include children and older patients. Minority patients are also more likely to be uninsured or lack continuous insurance coverage. For the rest of this presentation, I will use the terms Black, African American interchangeably. Although these may mean different things and have different health implications, but I will be using the terms used in the literature to describe these groups. Even before COVID-19, African Americans have a higher rate of mortality than any other racial or ethnic group for 8 of the top 10 causes of mortality. And some of these specific diseases include cancer. For example, with cancer, cancer rates are 10% higher in African Americans as compared to those of European descent. African Americans also have a higher risk of certain diseases such as hypertension and heart disease. African Americans are 30% more likely to die from heart disease than non-Hispanic whites. And African Americans make up more than 33% or 1/3 of patients on dialysis, despite the fact that we represent only 13% of the population. More directed to this study is obesity. African Americans are more likely to be obese than any other member of the population here in America. And concomitant with obesity is a metabolic disorder, diabetes. African Americans are more likely to have diabetes compared to non-Hispanic whites. And diet is not the only reason why. Cortisol response to stress, along with high allostatic load, food deserts, and other factors play a role. So I wanted to now get into describing my study. And I studied a data set obtained over 12 months from 2004 to 2009 pertaining to physical activity, health, healthy lifestyle behaviors, including cancer screening, tobacco and alcohol use, and the relationship with perceived discrimination. I also looked at the relationship between spirituality or religiosity and healthy lifestyle behaviors. So right now, I am going to talk about the portion of my work that was a descriptive correlational study, which was nestled within a community-based randomized control intervention that was undertaken over 12 months with data gathered at baseline, 3, 6, and 12 months. The primary aim was to study whether or not there is a relationship between perceived discrimination, perceived health, spirituality, and healthy lifestyle behaviors, specifically tobacco and alcohol use. After I cleaned and coded the data, and in some cases transformed and recoded it, I ran descriptive statistics and then multiple linear regression on our variables of interest. The mean age was 45.07 years old, and the spread was from 20 to 78 years old. More of my sample was female than was male, and more were in a non-partner relationship. And this is important as we talk about the social determinants, because being partnered is an indicator of social support and is associated with better health, especially when it comes to cancer care or recovery in the literature. And as you can see, 66.9% of our sample were not partnered. So that has implications on our findings and also our generalizability. In addition, only 51.8% were employed full-time, and 14.7% had an income over $75,000. The majority, the majority of our sample had a lower income of $35,000 or less, which is extremely important because this is a Bay Area sample where middle class income is $105,000. So even with the people in the study that had an income of $75,000 or higher, they would still be considered low income if their income was under $105,000 for this area. And this has meaning because poverty-related health sequelae are important in discussing health and health-related injury related to obesity, food deserts, and all the other factors that were discussed in the beginning. So next, I looked at perceived discrimination as my independent variable, and I regressed it on health status, which is my dependent variable. And what I found was that none of the variance in my dependent variable health status was explained by my model. That tells me that that there was no strength, meaning there was not statistically significant. Thereby, based on this result, perceived discrimination was not associated with health status. In looking at our model, you can see here that one of the questions asking if healthcare professionals listen more to whites than African Americans. This is on our questionnaire to determine perceived discrimination. This particular question had the strongest unique contribution to explaining the dependent variable. However, none of these variables were statistically significant. Because this is a work in progress, I will finalize my findings on spirituality and the BMI variables within the coming months. But these are so far my findings, and now to discuss my take-homes or conclusions. There were some limitations on, I would say, external validity, and that's how well the outcome can be expected to apply to other settings related to the small sample. The data might be skewed towards self-selecting or selecting for lower income people who have more time to sign up for studies. So I'm looking at income as one of the factors, higher income being protective, but lower income people might have more time to sign up for studies, which might affect the data. For future work, I want to look at the questions regarding religiosity and perhaps allow more selections. There were only 2 choices, and people were filling in answers that they thought would help explain their levels of religiosity. There weren't the questions we were asking. And so within that same idea, I think it might be important to do a mixed method design so that I can follow up with interviews to capture some of the missing data points on what people wanted to say in longhand form on the questionnaires. And then finally, in our post-COVID-19 era now, we want to include larger samplings of men because they're a higher risk category for COVID-19 to have generalizability to those who are most affected by death from COVID-19. And there's more to say about that, but I'll let you ask if you have any questions here for follow-up.
Thank you, Carla. Could you talk a little bit about those variables, the BMI and spirituality that you're working on next, and what you think you might find in that regard?
Yes. So I'm looking at BMI. BMI is a calculation of height and weight, and we are determining whether or not the intervention improved BMI from baseline to 3 months. And I suspect that I'm going to find that there were improvements in the BMI from baseline to 3 months, but I haven't completed the calculations for that portion of the study as yet.
And then the role of
just
spirituality.
eyeballing the time. Yes. So the literature suggests or tells us that spirituality is protective for the health of African Americans, but not necessarily protective for the health if you compare it to whites. And so I expect to find, if our study follows the literature, that there might be a protective effect of spirituality in the health of the population.
Thank you. And if you were going to pursue this qualitative angle that you mentioned, what kind of topics would you probe in those interviews? Where would you what would your interview guide look like?
Well, one of the things that I touched on, but I didn't go into depth about, is that this study used 7 principles of Afrocentric cultural sensitivity, I should say. And it would be important to allow the research participants to guide the questions. And so using a community-based participatory research approach, I would first have focus groups and ask the participants what is most relevant to them, and then form my questions around the group ideals and the group mores, and also being important that I'm African American, so with Afrocentric focus, it's important that the researchers are also have the same cultural experience as the participants, because trust is a large component in whether or not research subjects are forthcoming about what they really feel and what they really think. And so I would ask open-ended questions to elucidate what factors are most important to the research participants using community-based participatory research approach.
Thank you so much. This is such important work, and I really look forward to hearing more about what you find as you finish wrapping up the work.
Thank you so much. I so appreciate working with you.
All right. So our next speaker is Regina Orozco, and her dissertation is Perceived Influential Factors Among Female, Black, and Latina Nursing Students for Entering the Nursing Professional Through the Vocational Nursing Entry Point. And Regina's chair is Kupiri Ackerman-Barger.
Hi, good morning. Thank you, Dr. Bell. My name is Regina Orozco, and I'm a PhD candidate at the UC Davis Betty Irene School of Nursing. Sorry, I'm so nervous. I don't know why this is silly. Okay, take a breath. All right, so I wanted to start by saying it would be a missed opportunity not to open my presentation by recognizing and honoring those who are currently protesting against the structural racism that continues to breed hatred and violence to the people of color in this country. That same racism also plagues our educational institutions and actually frames my dissertation. So I would ask that you would please join me in 9 seconds of silence to honor those that have unjustly lost their lives to this violence. Thank you. So my dissertation is on the influential factors among female, Black, and Latina nurses and students for entering nursing in California through the vocational nursing route. So according to the literature, what we know about race, ethnicity, and nursing is that Black and Latinx and Native American populations are actually underrepresented in medical professions in the United States. So nursing specifically has an urgent need for a variety of reasons. And the first one being that nursing has a great impact on healthcare at the individual level. We're on the floor, we're at communities, we're out in the community, we're at these clinics where we're one-on-one with our patients. 3.8 million nurses are currently employed in the United States, and that makes it the largest medical profession out of all the professions that we have, the largest population. And in California, we have a little over 423,000 currently licensed. So that's our rationale for being so urgent to increase our need of racial and ethnic diversity in nursing. The importance for diversity comes from the literature as well. The literature talks about the service to underrepresented minority communities. So when nurses graduate or physicians graduate, medical professionals graduate from these professions and go out into the community, they're more likely to serve in underrepresented minority communities. Building trust to possibly decrease health disparities. There are lots of literature out there that discusses that when there is a concordance of racial and ethnicity amongst the provider and the actual patient, that a trust is built between them. It may improve access to healthcare for people of color, and it may assist in improving nursing shortages. So that same topic we've been talking about for a really long time. When I started looking through the literature, I started pulling the Seminal Reports and kind of getting some big information to get me started on where I really wanted to take this topic. And the IOM the Institute of Medicine released in 2002 a document entitled Unequal Treatment Confronting Racial and Ethnic Disparities in Healthcare. And in that report, their recommendation was to increase minorities in the profession to decrease health disparities. And then, sorry, my little camera's in my way. And then in 2016, the AACN actually released a position statement that said to increase diversity in healthcare workforce. So what this diagram is really telling us with all these words on it is that through all of these years, 14 years actually, we actually noticed that there's really negligible change in increasing that minorities in the healthcare professions. So currently, the nursing trend is that there are two licensed entryways to enter into nursing. The first one is a licensed vocational nurse. And really in the literature, there's no distinction between the two entry points. When I was looking through them, they kind of lump everyone all together, but there actually are two distinctual points. And the licensed vocational nurse is a shorter program. It takes about 18 months to get through most of them. Some of them are even as little as 12. The prerequisites are on a narrower scale compared to the registered nursing. You don't have as vigorous of science classes. They're a little bit shorter. Anyway, so they also have a narrow scope of practice as well. So the licensed vocational nurse will terminate in either a certificate or it'll terminate in an associate's degree. For the registered nurse, of course, again, just the opposite, broader scope of practice, more vigorous prerequisites. But it also takes about 2 years for most programs. Some take a little shorter if they're fast-tracked. Some take a little longer if you're including your BSN. But anyway, these registered nursing programs are on a higher level. You can end and terminate with an associate's degree, a bachelor's degree, a master's degree, and some are even direct entry doctorate degree programs. The main difference between the two, as far as financial gain, is that there's about a 50% increase in wage. So whereas well, it could even be higher in California, I should say. Whereas your vocational nurses could be making anywhere from $25 to $35 an hour, your registered nurses can be making anywhere from 50 to 100, some places even more. So why is this important? Well, if we look at the general population of licensed nursing in California, comparatively speaking, we can see that the white population of registered nurses licensed currently is about 52%. And the licensed vocational nurses are about 2%. So that's a huge disparity between those two numbers. In the Black population, it's 5% registered nurses versus 21% registered LVNs. And then we have a 7% in the Latinx population for the RNs versus a 43% percentage for our LVNs in California. So that is a major difference when we look at white population being higher, significantly higher in our RN population versus our Black and Latinx population. And what's another really important number is that if we look at the general population, 38% of Californians are considered white non-Hispanic and 39% are considered Latinx. So we have this almost equal level of general populations, and yet we have this disproportionate number of LVNs to RNs. And this is according to the California Healthcare Foundation in 2017. So what this tells us is that LVNs represent the most diverse group of nurses. And if our literature is lumping them together, no wonder we're missing that they're present. They're just present in a different route into nursing. So this also tells us, which I thought was most important, is that underrepresented minority populations are interested in nursing. They're just entering through a different route, and we need to talk about that route. So my research question was, what factors among female Black and Latina nurses and students influence their decision to enter nursing in California through the vocational nursing route? So my study design, and I'm still currently working on this, my study design is a qualitative descriptive design meant to really capture what my participants are saying. I'm using in-depth interviews as my data collection, and I will be using data analysis as a thematic coding, using in vivo coding as my first round of creating codes. My inclusion criteria: self-identify as Black and or Latina, self-identify as female. That's the dominant gender in our nursing population. And when I looked at the research, it talked about the differences between why people entered as a female versus a male. And I wanted to make sure that I captured the majority at this point, and figured that later on they could look at other genders. And of course, there's multiple genders, but I was just doing the dichotomy male-female when I was looking and finding literature associated. Enrolled in a vocational nursing program in California or has attended a vocational nursing program in California in the last 5 years and had completed their primary education, at least graduated in the United States. All right, so currently I have 7 interviews that are completed, and I've got 5 more interviews pending, including one at 12 o'clock today, and one at 7:45 in the morning tomorrow morning. So I wanted to introduce 3 of my participants and kind of give you a little bit of quotes that I got from them that I felt were important to kind of describe what it is that I'm looking for. Modesta, who got to choose their name, by the way, all of my participants based on what they wanted and who they wanted to honor. Modesta is a 22-year-old Latina female who's currently enrolled in a vocational nursing school at a local community college. And she lost her mom at 15 to cancer, and that actually influenced her to become a nurse. Sabrina is a 33-year-old Black female who's currently enrolled in a vocational nursing school at her local community college. And when I had spoke with her, she had discussed about being in school and trying to achieve registered nursing for many, many years, and even started as a medical assistant. Serafina is a 28-year-old Latina who graduated from a vocational nursing school at her local community college. And she grew up on a border town, mostly grew up on a border town between California and Mexico, and went to a high school that was mostly Latinx, she stated, and mostly low income. So when I questioned them why the LVN route, sorry, there was like a little share screen here. Modesta stated, so I started doing my own research online, and then I met up with a counselor at school. And I even had a counselor tell me, women like you, people like you, referring to being a female and also Hispanic or Latina, he said, people like you don't make it. You need to change your major. So actually RN was my initial goal, but after having met with that counselor, I dropped a couple classes because he said, you're not gonna make it. So that ultimately docked me points on my RN application. And so I thought to myself, well, I have all the prerequisites done. What can I do in the meantime? I actually got accepted into the LVN program. Yeah, the LVN was kind of a second option. Sabrina stated, so I went to medical assistant school, and so I worked as a medical assistant while I was trying to finish my prerequisites for nursing school. So after I finally finished, you know, trying to apply and get into programs, RN, and not getting picked, so I decided to do LVN as a second option because you can also do LVN to RN bridge. So either way, it was going to be a long nursing process. Serafina stated, I did try to get into a BSN program, but my score, my TEAS test, just wasn't competitive enough. I went to a community college for it, and I applied for their associate degree program as well. The counselor said, you know, you should apply for the LVN just to have a backup. And I was like, I don't want to do the LVN. And you know, it's just one more semester difference in my mind. But then my science courses were expiring. I applied, so LVN was my plan B. I figured I'd already tried various times to do BSN or ADN, and it's just so competitive here in California. When I asked, do you feel your race or ethnicity influenced your career choices in any way? Modesta stated, I do believe so because growing up, my parents worked in the fields, and my parents always told us, you know, I don't want this for you. And they threw us into the fields too. When I was a teenager, my uncle was co-owner of a large agricultural company here. So he offered us summertime jobs, and they kind of used that as teaching, like, this is not what you want for yourself because it's hard, backbreaking work. Sabrina stated, I don't think race had anything to do with it. I do know now, being around the industry, that there are a lot of African Americans and most are registered nurses, but it wasn't something that I just saw growing up. I didn't see any kind of real careers going up. So like my auntie, there is the only one that went to college and graduated and had a career. Everyone else just worked, or yeah, they just worked, so. Serafina stated, like growing up in high school, I already knew, you know, college wasn't an option for me because I kind of messed up in the 10th grade. So even the counselors at that stage would be like, maybe look into a vocation or trade. You know, what do you want to do? I remember a counselor even telling me, I did my makeup pretty, so maybe I can go into beauty school. And I was like, the options were just never really for me. So what is the importance of this research? Well, first and foremost, this gives a voice to Black and Latina LVNs that is currently not found in the literature. Many of my participants were eager to tell me their stories and were really heartfelt about the things that they were saying. And it gave me definitely a different perspective versus all the other articles I had read in my literature review to even get into this point. It made things so much clearer. And so I felt like this is really important to share with everyone. It also is going to help with nursing pipeline studies that more are needed. If we see so many people are trying to get in, whether it's a structural issue with our ADN programs being so impacted, or whether it's even getting in to begin with, we need to discuss and have more research on this. There's inequalities in nursing education, so this needs to be further examined. The entrance exams that are actually gatekeeping for a lot of these students who are trying to get in. The chancellor score, which is something in California that most people have never even heard of. Even the students didn't even know how to calculate their own chancellor score. It's another gatekeeper that's been placed in California on all the ADN schools that I actually looked through. And they use your GPA, your science classes, how many times you've had to repeat courses. And a lot of these students were working and needed to repeat their classes just to actually finish because they had their families to support, children and other things. So that was, of course, against them as well. Influences on counseling for nursing education, obviously, or hopefully, I should say, not obviously, hopefully you were as empowered as I was and as angry as I was when I heard that someone was deterring someone from actually going into the registered nursing program. If we have these counselors into the community college levels or even into the high school levels, because we're seeing that students are choosing their careers even earlier, middle school, high school, then we need to be actually influencing these students and actually praising these students and helping them to get where they want to be, not and discouraging them on their goals. And this is a starting point for future research. So the importance for me was that when all this is said and done, you can read it and take away what you want, but we need to do more about it in the future. So thank you very much for your time. And I wanted to give a special thank you to my participants. First and foremost, for actually showing me that data has a face behind it. When I see numbers and we start getting really digging into them, I've always known there was a face, but when I was hearing their voices and their stories, it made me realize even more that we need to pay attention and not ignore that there's people behind those statistics that we read daily. To my amazing cohort and professors, I definitely would not be here without you. To my committee members, Dr. Piri Ackerman-Barger, to Dr. Elizabeth Rice, to Dr. Mary Lou de Leon Ciantes, to Dr. Susan Adams, and to Dr. Jacob Heibel. For my scholarship from the Gordon and Betty Irene Moore Foundation, and to my beautiful family, including my 2 beautiful grandchildren and my lovely cats who I love. Thank you.
Thanks so much, Regina. It's such important work, and the implications are so strong for our profession and the pipeline. Can you talk a little bit about men in nursing, and particularly men of color? Like, given their scarcity, why did you decide to limit your study to women?
Yeah, so when I originally started looking at the actual foundation for nursing in general, we did see this huge difference between men and women, and I mean that loosely, sorry, in a gender form. So we saw there was a large difference. Like I said, it was like a 90 to 10%. And when I started thinking about it, I really wanted to bring this majority voice so that we had a starting point. I wasn't excluding them because I felt like they didn't have a voice or I didn't feel like their voice wasn't important, but I really wanted to bring the forefront to the majority voices first, and felt like that study could definitely be something that we could look at later on.
Great. And what would you say to us in higher education? Like, what can we do, or what are some intervention strategies that you've been thinking about?
Well, there's lots of other quotes and lots of other questions that I asked the students. I really only presented a very small fraction of the data that I've collected so far. And some of the things that I'm hearing, number one is, first and foremost, is listening to what these people who are having trouble getting in are saying. So if they're telling you that they're struggling with their math or their English, we may need to hook them into the right resources so that they don't have to repeat courses, or help them to find ways to complete them, so that they don't have these GPA docked against them. The other big piece of it, and this is probably a little more political than I wanted to kind of go, but I feel like we as educators, and I say we because I'm also an educator at a community college, and I have been for 13 years, I feel like we need to fight on the level of the legislation to decide about these gatekeeping pieces that are in place, like the chancellor's score and the TEAS entrance exams. We've looked at literature and seen that those are just gatekeepers. We're seeing the SATs being questioned, and now we should start questioning these kinds of entrance tests as well. It's unfair to say that because you've got this score that you're going to be a better nurse, when we're looking at our numbers and seeing that we have high attrition rates in the first 5 years, regardless of who's graduating from school. And even then, I did see some data that stated that these underrepresented minorities were more likely to stay in their field and work versus others who wanted to leave at the bedside. So I think it's important that we look at the pipeline, how people are getting in, respect how they're getting in, and help them to get in instead of hindering them and pretending that it doesn't exist, which is what we're doing right now.
Great answer. I know you're still wrapping up this study. What do you see as your next step as you finish up? Are you going to continue with this line of work?
Yes, absolutely. It's interesting that that question came up because as an educator, I keep hearing time and time again, I know all of my other cohort has heard the same thing. What are you going to do with your doctorate degree? What are you going to do with it? And I work at a community college, so everyone thinks that I want to move on to a university, but I'm not really sure that I want to do that. I enjoy the diversity that the community college level brings. I feel like I want to help those who are actually at the community college level. I want to find ways to work with those at the university level to have grants and more research that's done for the community college level. There's not a lot out there, and I can see why. A lot of our community college professors are not needing to do research anymore, right? It's not part of their job requirement. So that kind of gets dropped off the plate when we get so busy. But for me, I want to continue this research and looking at this pipeline. I want to see if we really need these gatekeepers, and that's really my next step, is to figure out prerequisite courses so we can stop having these students take so many classes. Like Sabrina said, she's been in college for years. That's unacceptable. We need people out working, not here in school, taking more classes and wasting more money. I heard students say that they ran out of financial aid trying to get through the LVN and then the RN and MA. And so all of those things are causing a backup for them as well, financially, a burden for them. So that's where I want to go. I don't know where the future holds. I'm super excited about it. And I just only can hope that I can make a difference in the end. And even if it's only for a small few, that's my goal, is to make a difference. So
I'm sure you will. Thank you so much. And congratulations on very important work, and congratulations to all of our speakers today. This was a wonderful session, and we really appreciate you sharing your work. I want to also just remind you that we have another session today at 11:30, and that one is with our Master's Science in Healthcare Leadership students, our nurse practitioner students, our physician assistants, and master's entry program in nursing. So those students will be showing their work at 11:30, and I hope you'll tune back in. I think it's going to be a fabulous session, as this one was, and many thanks to everybody who participated. Take good care.